So basically the idea today is this is going to be 2 sessions. This is going to be a very simple form of how to handle codes in an ER or in a hospital setting. We will give some basic idea in the lecture today. And if you guys can come tomorrow also, tomorrow is going to be a much more interactive session. So by the time you leave tomorrow, you know how to handle almost any codes. Wallahi? Good. So that's better. So, okay, I'll see you tomorrow then. Okay, so basically, what happens in a court situation, every institution is different. Yani what I wrote over here happens in United States. Doesn't have to happen over here. Because every country has a different requirement, has a different things that they can offer. You understand what I'm trying to say here? So in a court situation, in a hospital, a team is necessary. There's always a team. There is a court team, there is a trauma team, every team that is available. In a trauma team, there is a general surgeon, there is an orthopedic surgeon, everybody is involved in the trauma team. So there is a code blue team. You know what a code blue is? Code blue is when the patient is unresponsive and the patient is going through a VFAB, VFib or VTAG and comes to the emergency room. That is what we call code blue. Are you with me so far? Are you okay with me so far? Okay. So in US, when we have a core team, we have one leader. So we have one leader who's basically taking a charge and making sure that things are done in the right way. There's one leader, there is one person, we need 2 people to perform the CPR. Because CPR is not easy. It's a difficult time, difficult task. If one person keeps on performing the CPR, that person is going to get tired and it will be difficult for him to. And if the CPR is not performed properly, it's useless to perform CPR, right? I mean, you have to have a proper force, like it has to go 2.5 inches deep, and it requires efforts. So ta'ban, people get tired, so there has to be 2 people performing the CPR. So today I'm going to go over some very basics and some rhythm strips, but tomorrow it will be a lot of interactive sessions and you will learn a lot tomorrow, inshallah, and also today. Okay? So basically, and one person is taking care of one person takes care of the IVs. The person who takes care of the IVs also gives IV medications. So he or she is not just putting the IV, but also giving IV medications that is needed. So are you okay? So this is a team. This is a core team. In an ideal situation, we need a core team. But I know over here it's different. It's one person doing everything, or 2 person or 3 person around the patient doing everything. So whatever is available, one person has to take a charge and inform others of what to do and what not to do. So that is one of the basic requirements. So let's take an ACLS case scenario. So a 50-year-old male suddenly collapsed in the hospital hallway. So a 50-year-old, you get a call that on the 2nd floor, a patient was visiting, a relative was visiting a patient, and he suddenly collapsed and fell on the floor. So what happens? The patient gets brought to the ER, right? They bring that patient to the emergency room. Are you guys understanding what I'm trying to say here? So that patient gets brought to the emergency room, then the sequence of events what happens. So whenever somebody passes out, you have to make sure that whether the patient is responsive. So you will assess, hey, what's going on? Are you okay? Do you have any chest pains? Are you short of breath? Do you have any weakness in the arms or legs to make sure the patient did not pass out because of the stroke? So that is the first response that we try to check for the responsiveness. If the patient is unresponsive, now when the patient is unresponsive, it means basically you are checking for the response because you have to take care of the airway. When the patient becomes unresponsive, the tongue gets clogged into the throat and closes the airway because the muscles in the throat becomes very relaxed and the tongue basically stops the airway going in and out. So that is why responsiveness is the first thing to carry. Because in any code situation, we have to remember A, B, and C. A is the airway, B is the breathing, and C is the circulation, right? So that is why assessing for the responsiveness is very important, because unresponsive patient cannot take care of his airway. The reason we are all breathing right now because we are all alert. We are taking breathing in and out, we are controlling our tongue, right? Because the muscles over here control the tongue, does not close the airway. I know I'm talking very basic, you already know that, but we will go slowly and progressively forward so that everybody understands everything. Is that good? Yeah. Or am I being too basic?
No, it's good.
It's okay. So once you check the responsiveness, then we call activate the code blue. So the leader, whoever the leader is, you are the leader, says this is a code blue situation. So activate the code blue emergency system, and then after that, once we check for the pulse, okay? We check for the pulse and we see whether the patient has pulse or not, whether the patient is breathing or not. You know, if the patient is not breathing, airway is hugely compromised, right? And we check for the pulse, because if there is a pulse and we have a rhythm, we know what to do, because there is a difference in the treatment. Let's say if the patient has pulse and we hook up the monitor and we find that the patient is in VTAC, there's a difference. There is a difference in treatment for a pulseless VTAC versus the person who has VTAC with a pulse. The treatment is different. So having pulse, knowing that the patient has pulse is very important, right? So we check the pulse. That's why we check the pulse. So let's say you check the pulse and the patient does not have any pulse, right? We are going with the scenario that the unresponsive 50-year-old patient that passed out on the second floor and now brought to the ER does not have a pulse, is not responsive, not talking. Okay, so if airway is compromised, there is no circulation because there is no pulse. So when you don't find any pulse, what is the first thing we should do? We should start CPR, right? So so I'm just going to go over very quickly some basic things about the CPR. Start CPR immediately. Why? Because we need to maintain the circulation. So what is the rate of CPR? The rate of the CPR is around 100 to 120 times per minute. So when one person is involved in doing the CPR, we all know how to do a CPR here, right? Everybody knows how to do CPR. We put the fingers together, mid-sternum, we put 2 to 4 inches deep. Yeah, right? So every 30 presses, we give 2 breaths, 2 ambu bag breaths, or 2 mouth-to-mouth resuscitation, depending upon whether we have ambu bag or not. Right? Are we all understanding each other? Okay, good. So we have a patient. So we basically know this, how deep we have to perform. So once you perform the CPR and you go 2.5 inches deep, you have to make sure that you give a full recoil. You don't have to take the hand away, but you give a full recoil, because unless you go give the full recoil, the blood is not going to get collected in the heart and it is not going to move forward with another CPR. Everybody understand what I just said, right? I mean, I'm sure you know all this, but I'm just revising it pretty quickly so that everybody can understand that, right? So we have to allow for the full recoil. One thing that we have to, please come sit up in front. There is a space here. Okay. All right. So one thing we have to understand, that whenever a patient who is very unstable, no response, no pulse, and getting a CPR done, we have to minimize the interruptions as much as possible. When do we interrupt the code? We interrupt the code only when we have to watch the monitor. Because we cannot continue the CPR and watch the monitor, we will not know what happened to what's going on with the monitor. When you stop the CPR, only then you can watch the monitor, right? So it should not be more than 10 seconds. We have to assess very rapidly things, right? Right? Everybody understand this? So these are very basic things that I'm going over, but we will progress slowly and gradually. Got it? You understand? Faham?
Yes.
Okay. So we all know that 30:2 is the ratio for CPR, right? 30 compression for 2 breaths. Everybody knows that in their room, right? And then, so once we know our basics, we attach the monitor. Okay? We attach, so this 50-year-old guy passed up on the 2nd floor, now in the emergency room, unresponsive, there is no pulse, nothing. And then now we have attached the monitor to see what's going on. CPR is already going. So we tell our staff, the leader, whoever the leader is, will say, stop the CPR, let's see what the monitor shows. Once we hook up the leads, we ask the monitor. All right? So we attach the monitor and rhythm check. So what does the rhythm check? This is the rhythm that we get. Okay? What are the things that this patient has? This patient is unresponsive, right? The patient is not responsive. Number 2, the patient has no pulse. The patient has cannot respond. So this is a pulseless. What is this? This is a pulseless VFib. So this is a pulseless VFib. Okay. So whenever you have a pulseless VFib, it is called unstable VFib, right? Because there is no pulse, the patient is not responsive. What do we do in the unstable? I will keep on calling it unstable because patient is unstable, right? The patient has no circulation, the patient has no breathing, so this patient will be classified as unstable, right? So unstable VFib. So what do we do when we have? We defibrillate the patient. So we do the defibrillation. How much joules are we going to use for defibrillation? We are going to use how much energy we are going to use. We are going to use 200 joules. Now, one thing I'm going to be very clear on that, you see different books, and different books will tell you different things. If you go to England book, they will start with 150. You will go to American books, they will start with 200. So you will find different books. We are not going to go into those things. We are going to discuss basic thing, how to handle the VFib situation. With books which I read it from, it says 200 joules, so I'm going to write 200 joules over here. So we give 200. So before we shock the patient, what did the team leader tell to the team? Get away, because if somebody is pressing or if somebody is touching the patient and he shocks the guy, the other guy is going to get shocked up too, right? So we're going to avoid that situation and you're going to say, clear the area, because we are going to shock the patient. So you perform 200 joules, and after performing the 200 joules, what do we do? So after the shock, check the monitor again, exactly. So after rhythm check, again rhythm check, once you have performed the 200 joules, you will see what the rhythm is. So the rhythm, so what is the rhythm now? Again, the patient is in VFib. The patient is in VFib, the patient is unstable, the patient has, so when this is present, whoever is the team leader or other people who are standing, they will check the pulse in the carotid, because carotid is the best place to check, right? This is the peripheral pulse, you check, you will not get a good response. This will not get a good response. Carotid is the best place to check for the pulses. So somebody has to put the hand on the carotid and check whether the pulse came back or not, right? Because if the pulse came back, treatment becomes totally different, right? We go to a different route. So the patient does not have any pulse. What do we do now? We defibrillate again. Okay? So we defibrillate again. Again, when we start for defibrillating, we tell the people to step aside so that we can do defibrillate. So while this is all going on, the team leader who's watching all this, so one of the things I'm going to tell you is that there has to be a team leader, because a team leader can stand on the side and see all what is going on. Because if the team leader is working, then he will not have enough. I mean, he's an insan, he's not a angel that he can take care of everything. So it will not be possible for one human being to assess everything and to guide and to make sure that everything is properly taken care of, right? So the team lead, so he will guide the other person to start an IV. This person definitely needs an IV, right? Even though I'm telling you this sequence by sequence, but in a real life, the IVs need to be started, right? Because we need to get an IV access. So whether the IV access is here possible, good. If the IV access is not possible here, we need to put a central line. So whichever way IV access is possible, we have to start the IV access. Because the patient has no pulse, not breathing, and there's no blood pressure either. Because if there's no pulse, you cannot get any blood pressure. So we start the IV access. At the same time, whenever we are talking about all this IV access, somebody has to start taking care of the airway also, right? Because we have just done the circulation part, we have not taken care of the airway yet. So airway has to be set. Now, there is a difference. If this is a trauma patient, the airway is handled slightly different versus whether this is not a trauma patient. You guys know what I'm talking about, right? If it's a trauma patient, we have to worry about cervical spine. So we cannot do a chin lift on that patient. We have to do a jaw thrust, right? Everybody knows about this, right? So let's say this is not a trauma patient, and this is just a patient who became unresponsive. We do a chin lift and we start the patient on umbu back, and somebody's breathing, pushing the air oxygen, and CPR is continuing, right? Is the sequence, everybody understands the sequence agreement? Okay. So the time that requires every 2 minutes, so 30 compression and 2 breaths, 30 compression and 2 breaths, it sort of takes 2 minutes of the time. So 2 minutes, after every 2 minutes you have to reassess the situation, right? So let's say, again, if the VFib is there, we continue the CPR because the patient is there is still no pulse, so we continue the CPR. We continue the cardioversion. Then we go to then we stop the CPR. After 2 minutes, we stop the CPR to see what the rhythm is like, right? Because once you're doing the CPR, the monitor is just going to flip-flop, right? So we stop the CPR, we tell the team leaders, stop the CPR so that we can reassess and check the monitor. Once we check the monitor, rhythm check is done. Now we get this rhythm. VTAC, right? So this is VTAC. So now we have a person on a VTAC. So what do we do now? We check for pulse. We check for pulse. The patient has pulse or not? The patient still has no pulse. The patient still have no pulse. So what do we do? So what do? We do defibrillate the patient. We defibrillate. So that according to my ACLS book, for VFib you start with 200 joules. For VTAC you can go to between 200 to 300 joules. So we defibrillate the patient. Is it boring or is it okay?
No.
Okay. Okay. So we defibrillate the patient with 2 to 300 joules because the patient is still unresponsive. The patient is getting oxygen with the umbu bag, and the patient still has no pulse. So then we go. What do we do then? After 2 minutes, let's say 2 minutes have passed, we check the rhythm again. Okay? We check the rhythm again, we stop the CPR, we rhythm check again, and this again the patient has VTAC. Okay? I'm making this sequence of events so just for you to know that this could happen. So we can learn everything from one to the other. So again we have a VTAC, the patient does not have any pulse, and then we do epi. So one thing I'm going to tell you is that when in the code, do we have epinephrine?
Yeah.
So in a code situation, when somebody is going through the code, one of the things that the team leader also decides is to make sure to let somebody in the team know that to prepare the medications. So it's not when she says to Rami, who's also in the code situation, now give me 1 milligram of epinephrine, and Rami is running to the pharmacy to get the epinephrine. No, the team leader should right in the beginning mention that to the team that I want these things to be ready, because time is very critical in these situations. Right? One of the most important things that you have to understand is that the earlier the defibrillation is done, the faster the defibrillation is done, the higher the chances of recovery. Everybody knows that, right? Okay, good. So we give epinephrine 1 milligram to this, and then after giving epinephrine, what do? We continue the CPR. We resume the CPR because when we give this epi shot to the patient, we want to make sure that the medication circulates. We want to make sure because when you give epi is given peripherally. It takes time for the epi to go into the heart to start working, right? So CPR has to be continued for the medication to circulate and get into the system. Everybody agrees on that, right? So we give epi, resume CPR, another 2 minutes pass by. 2 minutes is the critical time. 2 minutes is the time of breathing, CPR, and all that kind of thing, okay? After 2 minutes, every 2 minutes we reassess the patient. Okay, then we do the rhythm check again. We do the rhythm check, and this is what we get. Can anybody tell me what is this? Huh? No. Yes, very good. Very good. So once we have Torsad, what do we do with Torsad? What do we do with Torsad? Huh? Very good. So we don't give epi. We don't give this. So once we found that the patient has Torsad, we give 2 to 4 grams of magnesium. Please don't give 100 milligrams of calcium or 100 milligrams of magnesium. You have to be very aggressive with the magnesium. Unless you give the appropriate dose of the magnesium to the patient, the Torsad is not going to get converted. You have to understand that. Okay? Okay. So we give 2 or 4 milligrams of magnesium to this Torsad patient, and then what do? We do reassess the patient, right? We do another rhythm check after giving this. And when we do the rhythm check, this is what we get. This is what? No, this is not normal. Who? What? Somebody said bradycardia. Who said bradycardia? You said bradycardia? Yes, exactly. So this is sinus bradycardia. So does it mean that the patient has pulse now or there is no pulse? We have to check for the pulse again. So this patient has pulse now and is sinus bradycardia. How do we treat sinus bradycardia? Atropine. Who said atropine? Yes. How much atropine? First time? 0.5. We start with 0.5, then we go to 1 milligram, and then further forward. Let's say you give, I'm just giving you an example. Let's say you give 0.5 milligrams, the patient is still in sinus bradycardia. What do we do next? We go to 1 milligram. Let's say the sinus bradycardia is resistant. What is the next level of after atropine for sinus? Huh? No, we give epi. That's what we do in US. If the atropine does not take care of bradycardia, we do epi. Understand? So that's what we do. So we give atropine to this patient, and after giving this atropine to this patient, this is what happens. Patient converts to normal sinus rhythm. Alhamdulillah, patient is fine. So what do we do now? We have a patient who coded on the floor, came to the ER, got so much of shocks, got so much of medication into his system, but now is in normal sinus rhythm. His blood pressure is 120 over 80. His pulse is around 75 per minute. He's breathing. He's now alert. What do we do with this patient? Should we just send him home? ICU. Yes, exactly. Every coded patient should never be sent home, no matter how good the patient is doing, because you have done a lot with this patient. Because all these rhythms that he went through could mean that he could have an underlying heart disease, right? So we have to put him in the ICU to work him up, to do an echocardiogram to make sure that he does not have any wall motion abnormality. We do all these things to figure these things out, right? Right? So we shift the patient to the ICU. So this is one scenario. Let's discuss another scenario. And oh, by the way, anybody has any questions on this interactive session so far?
I have a question.
Yeah, please.
So how many rounds, if we had the bradycardia, how many rounds of atropine we could give the patient?
So that's a logarithm for the sinus for the bradycardia. So the logarithm for the bradycardia is that you get 1.5, you can give 1, you can go 2, but if it's resistant, you go to atropine, you go to epinephrine. And let's say if nothing works, then can anybody tell me if nothing works for sinus bradycardia and the patient is symptomatic, what do we do? Do we do the transcutaneous? Do we do transcutaneous spacing? Sorry? So this is what we do. We do atropine and epi, and the patient converts. Okay, all right? Or we give time, because this is sinus bradycardia. This is not a life-threatening rhythm that you have to fix it now. After some time, the rhythm corrects itself.
Even if it's like heart rate is 35 or 30.
No. With 35 and if it's 35 and 30, it's pretty low. You have to treat it. You have to go 0.5.
After epinephrine.
Yes, another epinephrine.
Yeah, after epinephrine, if it fails,
then you might have to go to transcutaneous spacing if the patient has resistant bradycardia. Everybody know what a transcutaneous spacing is? Yes, transcutaneous spacing is a temporary pacing that you put it's a small like a small pad that you put it over here, and it gives it gives a rhythm to the heart so that heart can speed up a little bit. If
مثل pacemaker بس جلدي
you put it, this is called transcutaneous. Cutaneous means skin. So you put it on the so
I don't think we have.
don't lie.
We definitely don't have it.
So if the transcutaneous spacing does not work, then the next step is transvenous pacemaker. But I'm just talking about, we are not going to go into that. We are just learning the rhythms and how to treat the rhythms. Okay? So So this is the one scenario that we discussed, and tomorrow if you guys can come, it will be a much more interesting session than this one. I know this is not that interesting, but tomorrow it's going to be much more interesting, much more interactive, and by the time you walk out of this room, tomorrow you will remember how to treat each other. Because everybody will get involved, everybody will be asked questions, and then, are you guys coming tomorrow?
Yes.
Are you sure?
Yes.
Okay, yeah. Yeah.
Shall I start with scenario?
Yeah, scenario number 2. So scenario number 2 is the same thing. So scenario number 2, again, still, let me just open this up so that I can read. So this is again scenario number 2. We have to have a team. We have to have a team, right? Again, the team is there, the team leader is there, somebody is there to watch the rhythm, somebody is there to do the CPR. Whether CPR is needed or not, we can decide that later. But a team leader should be there. There has to be a team leader. Because then he or she can assess whether airway is taken care of, whether IV is taken care of, all the intravenous medications are there or not. This is very, because we don't have nurses over here. We don't have nurses in the ER. Resident is doing everything. From the reception to the discharge, resident is doing everything. So when you are doing everything, then a leader should be there to decide what needs to be done. And every morning, you need to decide who's the team leader today for the COVID situation, right? Okay, so this is scenario number 2. Okay, a 52-year-old woman with, so a 52-year-old woman with a history of hypertension and type 2 diabetes presented to the ER complaining of chest pain for the past hour, radiating to her jaw. She complains of shortness of breath. The patient is placed on the cardiac monitor. Okay? So when the patient is placed on the cardiac monitor, and we check the pulse. So we put the patient on the cardiac monitor and we check the pulse. The pulse is there. The pulse is there. So this is going to be. So the pulse is there. This patient has stable VTAC. Why this is stable? Because the patient has pulse. The patient is responding, right? This is a 50-year-old, she's complaining of jaw pain. She's not unresponsive. Her breathing, her airway is not compromised, right? She's not unresponsive. She's not unresponsive, her breathing is not compromised, airway is intact, she has pulse. So she has a stable VTAC. Got it? Everybody's with me? So that is why assessing the pulse, assessing airway, assessing breathing, assessing circulation is important, because it gives the idea of what to do. Is the treatment for stable and unstable tachycardia, VTAC is the same? No? Or yes? No. So it is not the same. So that is why we need to differentiate between the stable and the unstable tachycardia. So this is stable VTAC, right? We all agree on that, right? So what do we do next? What do we do next? So this patient is stable, right? When the patient is stable, we can do EKG or ECG. We can do the ECG so that, because ventricular tachycardia, supraventricular tachycardia, and VFib can kind of, sometimes it's very difficult to reassess what is actually going on a single rhythm strip, right? Single rhythm strip will only give only one lead, right? One lead. With a 12-lead EKG, you have a better view. You can make a better decision. So always when the patient is stable and you have a rhythm issue, get a 12-lead EKG. Okay? So we get a 12-lead EKG on this stable ventricular tachycardia patient, and we get and this is what we get. So this is a stable VTAC. So what do we do with the stable VTAC? What are the treatment options? These are the treatment options. Either you can give amiodarone 150 milligram over 10 minutes. Now the reason I wrote all this because you would say, oh, we don't do this over here. We give procainamide, or you can tell me and say we give lidocaine. Do we have procainamide here? Sorry? You have withdrawn. Do you have lidocaine? You don't have, so you just have amiodarone, right? You have lidocaine? No, this is not the lidocaine that you put on the skin to suture. This is a different lidocaine. Do you have lidocaine for the heart? Lidocaine for AD. It's a different thing. Yeah. So this is a different lidocaine. So please don't push the anesthesia lidocaine into the cardiac patient. Okay? This is important to know. Because somebody can say, oh, I just sutured that patient. The bottle is still not empty. Let's just give the lidocaine to the patient. No, you cannot do that. Okay? So you give the lidocaine to this patient and check the rhythm again. Okay? We check the rhythm again. We found that the patient has normal sinus rhythm. So what do we do? Are we done? What do we do now? No. We check for the pulse. We check for the pulse. Because a person, so we check the pulse and there is no pulse. So what is this? Oh, sorry? Who said what? Yeah. PEA, right? Pulseless electrical activity. That very good. Excellent. So whenever, even if you have a normal sinus rhythm, you always check for the pulse. You just don't finish the work. Okay, I'm done, the patient is good, and we are leaving. No. You have to assess the pulse every time. Because if the pulse is not there, patient has pulseless electrical activity. So what do we do when the patient has pulseless electrical activity? So what do we do when the patient has pulseless electrical activity?
Start CPR.
Start CPR? Is he right?
Yeah.
Right? Because the patient has no pulse, right? So how to confirm? We start the CPR, and then what do we do? We start a CPR with the same compression type, 3 to 10. But what is whenever you have pulseless electrical activity, it's a good rhythm to have, because the most common reason for pulseless selectivity are reversible causes. But it has a lot. The bad thing about pulseless electrical activity is that the mortality of this rhythm is very high. So pulseless electrical activity is very difficult to turn back, but if you are able to find the cause of it, you can reverse it easily. So what are the main causes of pulseless electrical activity? Identify them. Consider what are the main, so H's and D's. So if you can, let's say the patient has tension pneumothorax, or the patient has hypothermia or hypoxemia or even dehydration, you can give fluids and turn it back. You can correct hypoxemia, the patient is hypoxic, oxygen saturation is 60%, you umbu back the patient or put the patient on ventilator, it turns back. Or the patient has tension pneumothorax, you reverse it, the pulseless electrical activity turns back. So tamponade, tension pneumothorax, thrombosis, coronary or pulmonary, PE can cause, pulmonary embolism can cause pulseless electrical activity. So you give heparin to the patient turns back. So this is a good rhythm to have, but unfortunately most of the time it does not, the mortality of this rhythm is very high. Okay?
It's hard to get to a conclusion.
Sorry?
When the patient is pulseless, it's hard to get the reason.
Yes, exactly. It's very hard to get the reasons. So we reverse the cause and then we administer medication. So we can give epinephrine also to the patient with the pulseless electrical activity. So we can give epinephrine in the pulseless electrical activity. We can continue the CPR. Can we shock it?
No.
No, we don't shock pulseless electrical activity. Okay, so we continue the CPR, and once we continue the CPR, and then if the patient returns to normal sinus rhythm, patient is cured, you find a reason and you correct it, patient is cured, and the patient is taken to the ICU after that. So I want to discuss these very basic rhythms today. This does not complete my presentation for ACLS because there are a lot more to be discussed. And inshallah, tomorrow I will discuss more if you guys can come. Okay? Is that okay? Was that good?
Yeah, it was great.
Or you already knew all that?
No, it was great.
It was good? Okay, inshallah. Okay, inshallah, tomorrow we meet at the same time, but tomorrow we will have more interactive sessions. We will throw all the live rhythms here, and they can barcode, they can.
هلا بكره يعني حتكون النظم موجوده معكم، يعني الطريقه انه بس كل حدا حيطلع كيو ار كود على الشاشه، بس انه كل حدا بيعمل له سكان ويمسك الموبايل بالعرض او على الشاشه ممكن يطلع كمان، فبيطلع عندكم النظم، يعني اللي حيصير انه الدكتور حيختار نظم او حيخبرني شو النظم اللي حنحطه، حيطلع نظم قدامكم ويسالكم اسئله شو بتتصرفوا بها، شو بنتصرف بهالحاله يعني كذا، جاوب. It's not a test.
It's not a test. It's not a test. But it will be repeated so many times. It will be repeated so many times that when you walk out this room, you would remember that by revision and revision again, that you will remember that how to treat these rhythms.
Should I show them?
Yeah. So the basic idea of today is to get some basics. Some basics which I'm sure you already know the basics. So to give you an idea about the basics so that you understand the basics, but tomorrow we are just going to hammer the rhythms. Different kind of rhythms, what to do in these rhythms, so that everybody in this room, once they see this rhythm, they would know what to do and what not to do. But today I want to give the basics, start first step and then second and then third. And this step. You understand? Yeah. Okay. Was it okay or? Yeah.
And how many rounds has to be done before we start?
We start. Okay. So that's a very good question. So there are like, for example, we take VFib, unstable VFib. So you do 3 rounds, 4 rounds. So there are different studies suggesting different things. So with the VFib, they are saying that now some new studies have come up with unstable VFib that you give successive 3 defibrillation at the same time. But again, this is just I will not do it. I've never done it. But if the cardiologist is there and he does it, I'm okay with that. But I will not tell you to do it because it's all experimental. I mean, if if the cardiologist is there, he can do it, then it is done. But if 30 to 40 minutes have passed by and the patient is not coming back, then you might have to call the family and tell them that that you have tried and done everything, patient is not coming back, and you have shocking is not painless. It's painful for the patient. So you have to be human, right? You just cannot keep on pushing you cannot just giving pain to the dying patient. So there has to be a time that comes that you need to decide that enough is enough, and get the family involved, bring the family and tell them that you have given them so many shocks, you have given them so much of medications, and you have done everything that is needed to be done. Patient is not coming back. We might have to stop this.
Even if it's still VTAC or VFib, what's this?
No. VFAB, VTAC, you need to continue. But I'm going to tell you one thing with my experience. If you continue doing that, patient will go to asystole. Patient will go to asystole very quickly. These riddles will not hang on over for 2 days. No, they will not. The heart does not have that kind of musculature. It's not an elephant heart. It's human heart. You know, also you have to remember that VFib and VTAC are mostly happening in patients who has coronary artery disease. So their heart is already very weak. So they won't hang around for a long time. The patient will eventually go to asystole. And when the patient goes to asystole, you just tell them that now there is a straight line. You cannot fix that straight line. Right, guys?
Yeah.
How many of you have gone through this scenario in a real life?
I think all of us.
All of you. So you, in the end it's an asystole, right?
Yeah.
Yeah. So it does go to asystole. I usually do code for 30 to 40 minutes max, and after, if 40 minutes is not changing anything, I mean, if the asystole comes in 20 minutes, we know that this patient is not going to make it. And we tell the family that, hey, listen, the patient is in asystole, we have given epi, you tried epi for asystole, you give, CPR, nothing reverses, you just tell them, I'm sorry, we cannot do anything, we have to terminate the call. Right? Question? Oh, sorry, yeah, go ahead. Go ahead. No, just tell them that how tomorrow what we are going to do.
بس انه بكره اللي حيصير انه انه كل حدا بيعمل سكان للكيو ار كود تفتح عنده على الموبايل او فينا نضغط على الشاشه. وانا مثلا يعني الدكتور يعني حيعمل سيناريو مثلا بيكون مريض كذا وبعدين هو بيختار شو النظم اللي حيطلع بيقول لنا شو نتصرف وبعدين نشوف اذا صح ولا غلط. وهون هذا يعني حتى اذا انتم بين بعضكم انه ببعث اللينك انه ممكن انتم تستخدموه مثلا ممكن يصير هون اذا غيرته ممكن يصير فيفل مثلا. ممكن مثلا انه اعمله مثلا رفع لوزنية مثلا.
So you need to put the vitals in there, yeah.
So this is what we're going to do tomorrow.
Yeah, we are going to we'll keep on changing the rhythm and we will discuss the treatment. In this way, and we will do it multiple times, multiple scenarios, so that when we do that, everybody will probably learn something before they leave. Right? I mean, all of you guys have not witnessed codes, right? Has everybody in the room has witnessed codes? So whoever not has witnessed codes, when they see this, they will have some idea of what to do when the patient shows up in the ER. Right? Make sense? Okay. So tomorrow it's going to be much more interesting than just a slide code that you got. But I just wanted to make sure today that you guys are getting some basics done. But you already know the basics. I mean, you're working very hard downstairs by yourself without any supervision for the most part, right? That's what you guys are telling me, that there's no supervision, no teaching. So I'm just trying to see if this would help a little.
No,
Okay? Okay, inshallah. Okay, thank you very much. We'll see you tomorrow around 7:30, inshallah. Okay. Thank you.